Neurology quiz number 34. What is the posterior reversible encephalopathy syndrome, or PRES? PRES is characterized by reversible subcortical vasogenic brain edema, typically in the posterior regions, associated with acute neurological manifestations. PRES can be secondary to severe hypertension, autoimmune disorders like SLE, polyarthritis, etc., eclampsia and preeclampsia, hemolytic uremic syndrome and thrombotic thrombocytopenic purpura, bone marrow stem cell and solid organ transplantation, medications such as cyclosporin, tacrolimus, bevacizumab, cisplatin, interferon alpha, cyclophosphamide, among others. 50% have renal failure. It is not clear if this is secondary to hypertension or autoimmune disease, etc., rather than an independent risk factor. Symptoms in order of frequency are as follows: encephalopathy in 50 to 80%, seizures in 60 to 75%, headache in 50%, visual disturbances which include decreased visual acuity, field defects and cortical blindness in 33%, focal neurological deficits in 10 to 15%, and status epilepticus in 5 to 15%. MRI is the imaging of choice. It typically reveals vasogenic edema on FLAIR and T2 in the bilateral parieto-occipital regions, which may be asymmetric. Subcortical white matter and often the cortex are affected. Scans may also show coexistent involvement of frontal and temporal lobes and sometimes the cerebellum, basal ganglia and brainstem. There are three major MRI patterns: parieto-occipital dominant as described above, superior frontal sulcus lesions, and holohemispheric lesions at the watershed zones. Restricted diffusion is seen in 15 to 30%. This presents as small areas of restricted diffusion within larger regions of vasogenic edema and can be associated with incomplete clinical recovery. 20% may show enhancement. Intracranial hemorrhage and sulcal subarachnoid hemorrhage can be seen in 10 to 25%. This figure shows axial FLAIR and T2 MRI showing parieto-occipital hyperintensity. This figure shows FLAIR MRI demonstrating the frontal sulcus pattern and the holohemispheric watershed pattern. Pathogenesis. It is theorized that rapidly developing hypertension overcomes cerebral autoregulation and causes hyperperfusion, breakdown of the blood-brain barrier, and interstitial extravasation of plasma. Posterior brain regions are particularly susceptible to hyperperfusion as there is little sympathetic innervation in the posterior fossa. It is also postulated that a systemic inflammatory state may cause endothelial dysfunction. Treatment of hypertension is important, with an initial goal of reducing blood pressure by 25% within the first few hours. Marked fluctuations in blood pressure should be avoided. If provoked by a drug, the medication should be discontinued. Other underlying conditions such as preeclampsia, eclampsia, autoimmune disease, etc. are treated appropriately. Anti-epileptic drugs are used when indicated. Prognosis is generally favorable and 75 to 90% recover fully. Persistent neurological deficit can occur in 10 to 20%, and such deficits include hemiparesis, seizures, and decreased visual acuity. Mortality rates of 3 to 6% are reported and are often due to intracranial hemorrhage as well as diffuse cerebral edema and increased intracranial pressure. PRES can be recurrent in 5 to 10% of cases, and this is more common in patients with uncontrolled hypertension.